So thirdly, use. Now, we can look at use in different ways, different perspectives. Mainly, the measures of use are from two different perspectives, different ways of accounting for where the data comes from. Firstly, is population-based, so where the individual population is counted. For example, we can have immunization coverages, emergency missions for asthma, we count the number of people, that's population-based. Service-based is when we look at from one service or one area, the proportions to another. So GP referral rates, proportion of patients from an area admitted to a specialized center. So this is a different perspective we can look at use. So let's look at some examples of this. First of all, this is a service-based measure of use. So you look at the different general practitioners from Finland, and we're looking at how many are referred to per consultation to a service. And out of 1,000 consultations, some GPs make very little referrals to secondary care, and some make way more. This is about a 15-fold variation there. Why is that? Some family, this is generally, general practitioners. Some in just one country. Really, can disease really vary that much? Or is it some that are saying, are dealing with more of it? More experienced GPs are not referring, more inexperienced GPs are referring lots? Or is it the other way around? Some are more safe. We don't know if it's good or bad, but it is a 15-fold difference. It's quite dramatic there. This is another service-based example where we're looking at districts of the states. And this is about the ratio of using a branded version of drug outside patent or a generic version when the generic version is available. And you can see here, there's huge variation, isn't there? But this is probably a bit more obvious if you're looking at it from a healthcare perspective point of view. You probably want people to be using a lot more generic drugs and a lot less patented expensive drugs. But we can see how there's a lot less use of generic medicines in the South from the US. So what's going on there? Think about the big pharma we were talking about, the interactions there. Huge folds of variation. Oh, by the way, mindful, this is for Medicare in the States. So this is public. They're public over 65 years old, those drugs. So there is a federal interest in this because it's public money. So this is a different country, looking at England now. This is districts in England, and how many patients are admitted to a stroke unit rather than a normal ward. And we know for definite that actually, for this case, that stroke units are much better for patients if they have a stroke. So we know good is being in the stroke unit and ordinary ward, not so good for outcomes. And this is based on service-based as well because we are looking at districts. The PCTs are population districts in a sense. So on the way here, some are 100% admitting into a stroke unit, so dark blue ones, and others are below 50, below 50%, around 40%, right at the other end. That's a huge variation. So we know sometimes some places, in some districts, patients are getting 100% of the best benefit. Yeah. Right at the end, less than 50% on. This is all within one country, and it should be mindful that this is a national health service in the case of England. Okay. This is change for lower income countries, also very interesting. And this is like a population-based use of look on use. So we can look at a few things here. This is a use of immunization coverage. We can see that, again, there's huge variations. In some countries, some no data. the dark gray. But again, you can see that on a population level, you have huge variation in use. And population-based emergency admission rates to England for asthma. So this is not a referral, just a general turn up to emergency department for asthma. Huge variations. You know, we can assume the prevalence and there might be some prevalence and variation in asthma in district. But if this is population-based admission rates, are we assuming that much of a difference within one country? Why is that? And we might ask ourselves. Okay, so when we're presented with data like that on utilization rates, what can we do? And actually, you know, before we even get into that, it's important to consider a few things. Statistical factors is important to think about when you look at data. We know that sometimes data is incomplete. And so we always have to question the data. To make sure it's correct. Random variation can be statistical differences, chance, bias, confounding, and also, so that can explain some of the statistical factors. And so we can actually do something about those. Demand factors, we know there will be age, sex, population differences, and morbidity rate. Illness behavior we talked about. That's fairly hard to account for. And then also supply factors, the availability of services and of professional judgment. Okay, so when people want to lower variation, there's often a belief that there's a hidden agenda, like, you know, we want to reduce variation to the lowest level because that's the best. We can reduce costs. But actually, we don't know a lot of the cases, except stroke units, that whether or not the lower end or the higher end is better. For some things, it might be that we should be reducing things to the lowest of variation. So we need to think about different things. And then when we are seeing data, we might see that actually, when we want to know if people are reporting data in a way that's fair and also in a way that's transparent. Some places are under-reporting intentionally because they know we want to decrease variation. Also, for supply side, we also know that there are differences in, so when there's availability of services, it's pretty standard, we can measure that very easily. We know that the professional judgment varies a lot between countries we've seen. How do we find out and adjust for these things? We just need to know, we need to know that actually, for demand factors, that there are some things that can be accounted for. But things like illness behavior and professional judgment is actually very impossible to capture. And a combination of things that we might need epidemiological studies, and that routine data won't be able to help us answer all those questions. Okay, so this is an interesting figure and statistics from America, just to show us the sort of variation we're talking about in terms of professional judgment. And I think this is a good example of the variation in services in use and what's offered. So we've got things that are very low variations, very nicely presented. Hip fracture repair. That's reassuring, isn't it? Because your hip is either fractured or not fractured. And you hope that all fractured hips will be repaired. So that's very low variation. This is each of the line is a region in the States or a district. All the way to the other end, radical prostatectomy. Look at that variation. That's huge. I don't know from here. There's hugely divergent views as whether or not, and we don't know which of the district you want to be in if you have prostate cancer. Is it that you don't have a radical prostatectomy, or is it that lots are referred for radical prostatectomy? Somewhere in the middle is things like hip replacement, back surgery, bit of variation. But it's impossible to say, but it's very nicely shown. So what are we all thinking about now?